Good afternoon, everyone. Thank you for joining the Obesity Care Advocacy Network for today's webinar, the final in our summer series on today, the final day of summer, setting up our children for health and success as they enter a stressful school year. I'm Heather Hodge. I'm pleased to be your moderator for today's discussion. I am an employee of YMCA of the USA and have the privilege of working alongside and supporting the work of local YMCAs and communities all over the country as they work to help all community members live their healthiest lives through improved lifestyle health and health outcomes. Let me share a little bit about the Obesity Care Advocacy Network. OCAN is a diverse group of organizations that have come together with the purpose of changing how we perceive and approach the problem of obesity in the United States. We advocate for a continuum of obesity care, including evidence-based treatment and prevention options. As I mentioned, today's webinar is the third and final in the OCAN summer webinar series about obesity. You can find recordings of the first two webinars. The first one, a closer look at the impact of obesity through one's lifetime. And the second one, a community partnerships approach. Our community partnerships are vital in addressing obesity on OCAN's website, just like you'll be able to find the recording for this one there following today's session. A couple of things about the webinar itself. We will take questions from the audience later in our program. So at any point in time, feel free to put your questions in the chat. We will have those monitored as the session progresses. You can, again, submit those at any time. If you'd like to ask a question, obviously the easiest way to do that within Zoom is to open the chat box and send us your question along with your name and affiliation. We will try to get to as many questions as possible and have hopefully teed up today's conversation to maybe even address some of your questions before you have the chance to ask them. One thing to note is today's conversation is on the record and is being recorded, and links, as I mentioned, to the recording and additional information will be sent out after today's event. Let me get started by introducing today's panel, which represents experts with diverse perspectives on how to develop and utilize community partnerships to address obesity. First, I'd like to introduce you to Elizabeth Clark. Liz has over 25 years of experience as a school nurse and in School Health Services Administration. She's currently employed by the National Association of School Nurses as a nursing education and practice specialist. She's a former member of the board of directors for the National Association of School Nurses, a nationally certified school nurse, and a fellow of the National Academy of School Nurses. Elizabeth is currently the project lead for COVID-19 resource development at the National Association of School Nurses. Liz, we're excited to have you on today's panel. Next, let me introduce you to Paul Davidson. Paul serves as the Director of Behavioral Services for the Center for Weight Management and Wellness at Brigham and Women's Hospital in Boston and is an instructor at Harvard Medical School. His dissertation and much of his clinical work focused on eating disorders, and he speaks internationally about bariatric topics and heads the behavioral section of the annual Bariatric Summit. Dr. Davidson comes from a family affected by obesity and provides education to improve treatment and reduce stigma related to the disease. Welcome, Dr. Davidson. And lastly, let me introduce you to Susan Wolford. Susan is an associate professor within the Department of Pediatrics at the University of Michigan, and her clinical and research interests focus on behavioral interventions in the clinical setting for the treatment of obesity, particularly for severely obese adolescents. Her research explores the delivery of weight management interventions and outcomes for multidisciplinary obesity care. In recognition of her innovative work in the area of childhood obesity, Dr. Wolford served as the founding chair of the Obesity Society's eHealth mHealth section and is a member of the advisory board for the American Academy of Pediatrics Institute for a Healthy Childhood Weight. Welcome, Dr. Wolford. Welcome to this esteemed panel. I feel privileged to be able to facilitate a conversation with you today. To all of you attending, thank you again for joining us for this discussion, where we'll be talking about setting up our children for health and success as they enter a stressful school year. Now I'm going to kick off our panel discussion with an overview of obesity treatment. Many of you likely saw the Trust for America's Health 2021 State of Obesity report. In that report, they shared that the rates of childhood obesity are increasing. And now we're at 19.3% of US young people between the ages of 2 and 19 have obesity. That's about 1 in 5 children. These data have more than tripled since the mid-1970s, and Black and Latino youth have substantially higher rates of obesity than do their white peers. So when we have this context and this background in childhood obesity, my first question is going to be for Susan. Can you share what we know about childhood obesity from a medical standpoint, and how do health disparities come into play with this disease?
Thank you so much, Heather, for the opportunity to discuss this truly timely topic. Well, from a medical perspective, we know that obesity, which is the most common chronic illness in children, is associated with a number of health problems, even during youth, right? So they are, even while they're young, they are more at risk for things like sleep apnea, high blood pressure, liver disease. And we know that children with obesity are around 5 times more likely than those without excess weight to become adults with obesity. Indeed, while the precise risk varies by age and the degree of excess weight, we know that, for example, with adolescents, if they have obesity as adolescents, 80% of them will carry that excess weight into their adult lives, and therefore be at increased risk for comorbidities such as type 2 diabetes, cardiovascular disease, and certain cancers. Importantly, many of these comorbidities of obesity occur as a function of the amount of years that you have exposure to the excess weight. And so if that clock starts in childhood, then it means that one is more likely to develop the comorbidities at a younger age and have end-stage disease at a younger age, and therefore have this premature death, right? So we can't wait till they are adults to treat this. We need to intervene while they're yet children. And while the picture is sort of overall very concerning, as highlighted by the increases that you mentioned, it is particularly grim if we consider the health disparities seen for populations of color and for low-income populations. And so when we look at the highest prevalence of obesity recently in recent years, it's been typically among Latinx and Black populations. And if we consider data from 2018, the largest disparity is seen by looking at the data for girls, where the prevalence of obesity for non-Hispanic white girls was 14.1%, but for Black girls, it was more than double that at 29.1%. This highlights the fact that after all this time, decades of work in this area, we're still in dire need of ways to address these disparities. And it's important, I think, when we discuss this, to not limit the discussion to just personal choices, but to look at societal forces, population level factors that come into play, such as predatory advertising, where hundreds of millions of dollars are spent on advertising and programs targeting Black and Latinx youth, which causes youth of color to view 75% more fast food related advertisements than their white peers. Or we could look at the built environment that offers families of color easy access to fast food venues, food swamps, and freeways, but limited access to fresh fruit and vegetables, farmers markets, and fresh air. So unless we believe that this is just all external and it's all individual choices, we can't ignore the issue of microaggressions and systemic racism above and beyond poverty that increase stress and cortisol levels for people of color, thereby changing their physiology and increasing the likelihood of gaining excess weight. And all these things don't just impact adults, they impact children as well. And so we need to have a focus on addressing those issues for our youth.
Thank you, Susan, for really framing the conversation in the context within health disparities, as well as really helping to ground us in this conversation from the medical standpoint. For those of you who are joining us, we will get into some potential solutions, I promise, but we really need to unpack the challenge. And so I appreciate Susan kicking us off. My next question is for Liz. Liz, as we're thinking about this topic, what are some challenges that students with obesity face within a school setting?
Sure, yes, I'm happy to answer that. Research has shown that children and adolescents that are obese have lower educational engagement, more behavioral problems, and more school absences. And all of these, of course, can lead to academic challenges. So, within school settings, there are teams that monitor how students are doing. Oftentimes, they're provided by a multidisciplinary team in schools led by educators and other school staff, principals, and school nurses and other people who are, supporting that student. A common framework that they use is a multi-tiered system of support, or MTSS. And this focuses on the whole child, really looking at, how they're doing and how they can be supported academically, including behavioral support, emotional, social supports, and dealing with absenteeism. And dealing a little bit more about behavioral issues, the school nurse is often the first person who will identify a student is struggling with some social emotional issues. And, the school nursing office is a safe and trusted location within the school. So we have many students who arrive there and have various needs. Prior to the pandemic, about 1/3 of student visits in the school nurse's office were related to mental health concerns. And so, I think it's important to realize that, school nurses are really those frontline healthcare providers. Students, as Susan mentioned, that are Hispanic and non-Hispanic, Black, racial, and ethnic backgrounds do face more barriers in, receiving mental health support, and schools oftentimes do provide that for students. So students frequently report to the school nurse with those non-specific healthcare complaints, right? It's those headaches, stomach aches, just not feeling good. They may be emotional, they may be crying. And, these symptoms can be identified as stress-related symptoms, anxiety, depression, other things that the students aren't even aware of. They don't know what's going on. And, school nurses work closely with the school mental health team, with the counselors, the school psychologists, the social workers, to determine if there are supports that are needed for the student, if the school can support the student with their social emotional needs, or if that's something that needs to be, taken care of in the community setting. Another thing that, we identified is absences and, school avoidance, not wanting to come to school, whether that's related to bullying or other issues. And, the school nurse does a really important job in working with students with attendance concerns, as well as other school staff, such as attendance liaisons. And students who miss 10% or more of school are considered chronically absent. So if you're looking at maybe the first month of school, there's 20 school days. If they miss 2 days that month, they're chronically absent that month. And so really being on top of that and supporting students is important. Communication with caregivers is important because these are absences that are excused or unexcused. And so really communicating and letting the family know that we're there to support them in the school setting. Students with obesity often can face challenges throughout the school day with nutrition and physical activity. There's lots of classroom celebrations, food rewards that occur in the school setting. There are vending machines that may offer items, of course, that are low in nutrition and high in calories and sugar. And so, within the school system, it's important that, we look at non-rewards for food, vending machines that offer healthy alternatives. And there has been a lot of work in this area. The USDA did update their nutritional guidance, and many schools took advantage of that and really promoted that. But there's more work to be done, of course. So, schools do advocate for a healthy school environment. We want our students to be active. There can be challenges for students who are obese, regarding movement around the school. Accommodations may be needed in the classroom for appropriate seating and desks and those sort of things. So, it's really important that the school nurse works with the family and the healthcare providers to really establish a plan of care that will support the student and their needs in the school setting.
Thank you, Liz, for helping to put this conversation within the context of the school setting. And as we combine what we've learned about what the data is telling us, as well as the school setting, Paul, we know that this disease is nuanced and personal for children and families impacted. What have you learned from your experience as the father of a child experiencing obesity?
A lot. But first, I want to thank OCAN for inviting me to participate in what I think is an outstanding panel and webinar. I think the first thing that stands out in my mind is that kids can be cruel, and that a child with obesity is often bullied on many levels. And we see this in a variety of settings. And you have to really be somebody who is willing to go to the mat for your kid, because they have an uphill battle. Appearance is really important, unfortunately, for a lot of kids, especially for girls. My daughter is the one who is struggling with the issue. I was a boy growing up, and all the boys in our family all had weight issues. We wore husky clothes, but it didn't bother us as much. We were boys, and we would play around. It didn't have as much of an impact. For a girl, though, it can be particularly difficult, and kids can be cruel, especially at a time where social media rules. And the way kids look and the images that they're seeing, I think are very unrealistic. I do want to mention one quick thing is that about 66% of Americans have either overweight or obesity. So it's not an unusual condition. It is actually the majority state. But the kind of images that kids see, they're very restricted, and they show people who all, tend to look healthy and fit and active. I think I've also learned very carefully, it does not matter how bright or talented your child is. Regardless of those things, they're made to feel less than, not as important, not as valuable if they come, to school or to a social setting with excess weight. It really does have an impact on almost every element of life, from home, school, social life, friendships, moods, sports, sleep. We see a lot more snoring. My daughter, had to have her tonsils and adenoids removed because she was a very, very heavy snorer. My daughter was an outstanding dancer, and she was on a dance team for years, and she gave her heart, and she really was one of the best technical dancers. But as she got bigger and bigger, she got moved to the back over and over again until finally, I think it was her junior in high school, they basically kicked her off the team because she just didn't look like everybody else. It was heartbreaking. It destroyed her. And we went through a little crisis to try to help get things back on track around it. But, the people running the school had no idea the impact that was going to have on crushing a child's soul. And we need to really think about things very carefully. And unfortunately, as kids put on weight, they become a little less physically active, which encourages weight gain, which makes them less active. We get this spiraling down. So learn that very quickly. I also realize as a parent, you got to deal with very finicky food choices. I think we see that with a lot of kids of weight issues and trying to focus on that. And the fact is you can't make your kid do anything that they are not ready to do. So you have to kind of go with where they're at. And regardless, we did, and I hope the message to all you out there is you need to let your child know how smart, capable, loving, beautiful they are, and help build their esteem at every single size. That's absolutely essential.
Thank you. Thank you all so much for helping to lay the groundwork for this conversation, both from the experience of a parent, from the school environment, from the clinical environment. And obviously, it's hard to have a conversation about childhood obesity without putting it within the context of our current environment, which is living within the COVID-19 public health emergency. And according to one analysis, the prevalence of childhood obesity increased from 13.7% to 15.4% in just the first 9 months of the pandemic alone. And so my next question really is going to come back to you, Susan. As we think about the COVID-19 pandemic, we know it has certainly impacted students deeply in ways are still trying to understand and will take some time to uncover. But we know that one of the most devastating results is a widening health gap as a result of the pandemic. Can you share how you've observed this trend play out and how these two pandemics, COVID-19 and childhood obesity, are connected?
Thanks so much, Heather. So yes, really, when you think about COVID-19 and obesity, they are just such a bad combination, right? Because they both make each other worse. And while we're learning more about COVID-19 all the time, the evidence suggests that indeed those with excess weight have worse outcomes, and that this is even true in children. So whereas children tend to have milder courses in COVID in general, but they do have the multi-inflammatory syndrome in children, and that even that is, we see that happening more often, it appears, with kids who have excess weight. And so it is possible that these worse outcomes with COVID because of excess weight is in some part related to maybe patients being treated differently when they have excess weight. There are definitely biologic reasons why we might see this worse outcome. First of all, we know that obesity tends to cause a chronic inflammatory state, which then makes our response to an acute infection less optimal. But then afterwards, it can cause an overreaction. And we know that that's a real problem in COVID. And then there's this other problem, which I thought is very interesting, in that we know part of the right reason why COVID is so bad for us is that it has this spike protein that's able to unlock certain locks. And the lock it's able to unlock is called that ACE2 receptor. And we know that those are in our lungs. But did we know that there's more expression of those locks in our adipose tissue? And so it's easier for COVID to get in there, and the adipose tissue can serve as a reservoir. And so that's a real problem, right? But then we have, if that isn't bad enough, that COVID is worse than obesity, we have the problem that COVID is worsening the prevalence of obesity, right? And so that we knew very early on in this pandemic, we could see it, that it was changing the behaviors that were related to weight. And many of us have sat in clinics with patients and looked at the growth charts and said, oh my, together, we all just look at it and wonder. And we know that it's the pandemic. We saw that kids' activities were restricted, less organized sports, and home doing more sedentary activities with online schooling. So it wasn't surprising then when the data started coming out about excess weight, that indeed it was worsening. And I was fortunate enough to be able to work with a group out of Kaiser Permanente in Southern California, where we looked at data for about 200,000 children the year before, looking at their change in weight in 2019, and then looking at their change in weight in 2020. And across all age groups, they gained excess weight in 2020, but particularly of note, it was most prominent in the 5 to 11-year-olds, in the younger age group. And the CDC has looked at data for, I think, over 400,000 kids, and they have seen a similar thing. So we're definitely seeing something that's particularly in these younger children, that's a call for action there, definitely. And then, of course, we have the fact that there's a triple whammy to all of this, that both COVID and obesity have this disproportionate impact in communities of color, right? So due to the social determinants of health, including poverty and structural inequalities, communities of color have been hardest hit by the pandemic and having to work more often outside of the home and on the front lines. And so in the short term, we've seen that they are already estimating that there's going to be a decrease in life expectancy that's 3 to 4 times more than the decrease we're seeing for white Americans compared to Black and Latinx Americans. And so this will widen that disparity in life expectancy. And we're seeing it already. We're seeing that there's an increase in the prevalence of type 2 diabetes and hypertension during the pandemic in communities of color that have already been at greater risk for experiencing negative outcomes because of obesity. And now on top of it, negative outcomes because of the pandemic.
Thank you, Susan, for again framing our current reality, with the data and helping us to understand how the two pandemics together are producing even wider gaps in health across our country. And that leads us to the next part of this conversation, which Liz had mentioned a little bit earlier in her previous comments, but we're also seeing a mental health crisis stemming from COVID-19, and pediatric emergency room visits for mental health increased 31% from April to October in 2020. So I think this sort of rapid cycle, we're seeing the data change already, both in what Susan shared. And then Liz, my question for you, we know that this can be compounded for children living with obesity. Can you discuss and share with us some of the mental health challenges that children with obesity face and what steps we should be taking to support them?
Sure, happy to. There are several issues to share in response to this question. The first one is really related to weight bias. We all have sort of implicit bias, unfortunately, and research has shown that educators have expressed students with obesity are less likely to be successful academically. And so, we really need to impress upon educators that students with obesity are just as capable, right, as other students. Weight bias can also greatly impact students' relationships with their peers. This may they may have difficulty with friendship groups because of the bullying and teasing and things that goes on. And it starts early, right? It can start, in the 3 and 4 year olds. Children with obesity also experience stigma, which, is sort of that name calling, bullying, cyberbullying, which Paul mentioned, and the limited friendship groups. School staff are really responsible for being aware of what's going on in the school setting. They need to identify issues that are going on with students and intervene for students with obesity. Bullying prevention and intervention work does provide, there are lots of evidence-based curriculums out there for schools. Some schools have embraced them and are really, moving forward in that direction. Staff training is really critical when you're implementing a program such as this. And, the school staff really needs to know how to identify bullying, the school district's policies regarding bullying and enforcement of the rules. But as Paul mentioned, bullying can be covert. It isn't always easy to spot, right? And, all students should be encouraged to share any concerns that they see, that they observe with a teacher or other staff. Many communities do have an anonymous reporting system that they can anonymously report concerns, for safety, which includes bullying, cyberbullying, and any physical harm that students may be talking about to themselves or others. School staff does provide a trusting relationship, a trusting environment for students, and they offer a listening ear for students who are experiencing stigma and bullying. Many school health staff, school nurses, counselors, psychologists, they can set up frequent check-ins with students, making sure that students are doing okay on a regular basis, that may be daily or weekly. And students themselves should also learn bully prevention strategies, how to advocate for themselves, and various strategies on how to manage that. It's tough. I'll tell you, it's tough. School nurses, also do create individualized healthcare plans with behavioral supports in them as well, which includes regular communication between, caregivers, healthcare providers, and the student themselves, and talking about what sorts of supports they might need in school. The last thing I just want to talk about is the important role of parents, caregivers in monitoring social media for their students, and that, cyberbullying is starting earlier and earlier. I've seen instances, in elementary school where cyberbullying is occurring. And so, please be cautious. If you think this only happens to middle and high school, it does happen to elementary students as well. And looking for those signs of cyberbullying that you might see, a sudden change in mood, a child being withdrawn or depressed, not wanting to go to school, or regular activities that they, previously loved. And schools do have a code of conduct, right? And so if there is a cyberbullying issue occurring that affects the child's education, then caregivers can go to the school staff for support, school administration. And so make sure if those issues are occurring that you're reaching out to get support for your students.
Thank you, Liz, for sharing that piece. And then Paul, when we think about your experience in managing obesity in your family and in your professional experience, what impact do you think COVID-19 has had on accessing treatment and care for children with obesity?
Well, this is something that we see with kids with obesity, but also, as a healthcare provider in a hospital setting. There are just so far fewer in-person appointments. For a number of months, we went completely virtual. And I know many, many medical practices that did the same thing. And I've got to tell you, it's much harder to engage and keep a kid's attention when they are on Zoom. Teachers around the country have found this, probably around the world have found this. It's very, very challenging. And, I think an access issue really has been that health resources have been overwhelmed during COVID because they've had to place a priority on COVID treatment. I know we clear out tons of beds in our hospital, when we need to for surges to allow for that. But the same thing is, happening with private practices everywhere. So what that's meant is decreased availability for treating somewhat less acute issues. And when you look at it, people will see weight issues in kids as a far less acute issue that does not become a priority during this time. I think one of the things that shifted people's perspectives is the fact that, as Susan so well pointed out, the disease state of obesity in of itself and what happens, with what we see with receptors in adipose tissue has meant that obesity has been one of the greatest risk factors for COVID. And this has prompted governments to start to take a little bit of action towards trying to improving care there. But you know what? Care starts with adults and then slowly trickles down to kids. They're the very last ones to get the benefits. I also think that when you're dealing with Zoom and things like that, just as we are all on right now, you see us from here up and we look awesome, right? You can't see what's going on below. And so oftentimes as kids are putting on weight, a provider who's looking and speaking to them may not even see it. We also see, and this is something that Liz has really spoken to, there's been less access to mental health for everybody, but especially for kids. And my wife is also a psychologist, child psychologist, and we deal with this issue. And kids in our area have been warehoused in emergency rooms for weeks at a time, trying to get a psych bed. It's almost impossible. I have people coming up to me all the time. Do you know anybody who I can get my child in to see? Because nobody's accepting new patients. This is a huge issue. I also think an access issue is parents' increased caution about bringing their kids to health facilities out of fear of COVID. Even parents who have had vaccinations are reticent because there was a great lag in getting vaccines to teens, and kids from 5 to 11 have not been able to be vaccinated. I mean, luckily, data suggests that some of these vaccines may be very effective in treating them, but it hasn't gotten there. So until we're able to safely get vaccines out to kids, I think that hesitation about even engaging in bringing people to doctors is going to continue as an access issue as well.
Thank you. Thank you, Paul, for sharing that. We've talked a lot so far in today's conversation around just really what the data is showing, the challenges related to childhood obesity, as well as the intersection of the impact of COVID-19. Let's move into talking a little bit about how we can work together to find solutions. And those of you who are participating today and wanting to really think through that element of this, how can we work together to address the rising impact of childhood obesity? So Susan, I'm going to come to you first. What role do you think pediatricians and the medical community more broadly should play in helping children and their families prevent and manage obesity?
Well, thank you, Heather. Yes, I think there is a lot of space for a lot of people to help in this battle against this illness and the obesogenic environment that makes it so difficult for most of us to achieve and maintain a healthy weight, right? And so I think policymakers should invest in monitoring children's growth patterns and implementing policies that would reverse this trend. I think as a researcher, I feel like I want to speak to other researchers out there and say that there are many unanswered questions. And so I think there needs to be more funding and more work in this area, because how many conditions affect this many children? It is the most common chronic illness in children. So we definitely need more resources focused on this area. And then for providers, well, we play a key role because we're well positioned to be able to address excess weight with families. And the AAP has excellent recommendations to help pediatricians and pediatric providers discuss this issue with parents and with youth. And so I would recommend that people pop over to the AAP website to look at those recommendations. And I know that often people will say, oh, it's hard to raise the question. And so there are very good examples of how to help raise this question and ask permission to discuss it. Because of course, many patients, I mean, you don't want to be, you come in for one thing and all your provider wants to talk about is weight, right? So you have to be very sensitive about how you do it and when you do it, but there are ways to help broach that question. And then I like to say to providers that we should have a plan. And key in that plan is to partner with our patients and their parents, right? So we are not telling people what to do because that generally doesn't work anyway. So we want to partner with them to help them so that they can match their values with what they do. And motivational interviewing is one of those things that seems to help. And so we need to partner with parents and with patients and use these appropriate tools to help address the issue of excess weight and help people find the best approach for them, because it is not one size fits all. And then the L in our plan is to learn. We as providers need to learn more about this issue. We need to learn about ourselves, our biases, as we mentioned. There's lots of implicit bias here, and providers are not exempt from that. And so we need to learn where we have those and address that. We need to realize that there's a lot of stigma that patients encounter even in the medical setting and may cause them not to want to come. So we need to learn about that and ways to address it. And then we need to advocate. We need to advocate for our patients, for coverage, for obesity care, for safe streets, for all the things that we already know make a difference. We need to be an advocate for our patients. And then we need to network. All of this cannot happen within the clinical setting. Just the pediatrician or pediatric nurse practitioner in the room with the patient is not sufficient. And so we need to be a voice out there networking with community organizations and other groups to be able to make a difference and help families achieve a healthy weight in the midst of this pandemic, which is going to wax and wane. It's not going away next week, unfortunately. It's going to wax and wane. So we have to be able to have a plan to help our patients address this over time.
Thank you, Susan, for teeing up the role of community as well in your response, because it's a perfect segue to my question for Liz. In our last webinar, we discussed how community interventions, and as a representative of the YMCA, who's been working in this space alongside clinical partners, we know it's a crucial part of the solution for obesity. And so, Liz, as students return to some form of in-person learning in many schools, what opportunities do you see for both school and community-based solutions when it comes to childhood obesity?
That's a great question, Heather. It really does take a village, as we talked about, community members, parents, caregivers, healthcare providers, anyone who's concerned can get involved and provide feedback on school issues. One thing to look at is the nutrition program, and any school that receives funding from the federal government for school lunches or school breakfast has to have a wellness committee and wellness plan. And so if you have not had lunch with your student, please do that at some point if you're able to get into the school as a visitor and see really what they're serving. Is it healthy? Are there fruits and vegetables? Are there whole grains? Are there healthy beverages sent with that? And you can provide feedback and recommendations for healthy nutrition. There are many schools across the country that do farm to table, that are making meals again rather than prepared foods, which we sort of went through that trend. And so really advocating for a great nutritional experience, as well as reducing access to vending machines and snacks and those things that I talked about earlier. In elementary school, and policy, school district policy is something you can also look at and provide feedback for. And in elementary schools, birthday parties are huge celebrations, and say there's 3 birthdays in one day or 3 birthdays in 1 week. Are they going to have 30 cupcakes or 100 cupcakes they're giving out to the class? That can happen. And there are alternatives for that don't involve food or involve healthy choices. So really thinking about that is important. So there's other things that, you can do looking at physical activity. There are many states who do not have standards on how much physical activity students should participate in on a daily basis or weekly basis. And some do. And so you need to know what is that and what does that mean to my student in their school? And so, 60 minutes a day, could be 30 minutes of regular physical education, and then you have various recess and sort of things, right? But it does vary. Students with obesity may choose not to, run and play football. If they have asthma or other comorbidity sort of issues, it may be difficult for them to be very physically active. So they may, choose more sedentary type of activity on lunch. And so they're not getting that physical activity that you'd like them to do. So, encouraging students to also be involved in other activities that they enjoy. There are all kinds of clubs in many schools before, after, or at lunch they can be involved in. School nurses have done walking clubs, or, there's the dance team that Paul mentioned. Boys and Girls Club, of course, is a wonderful partner in the community for physical activity for kids after school. And many of our students do participate in those activities as well. School nurses are really a lifeline for students, and particularly children living in low-income areas. And, it's really important that you ask, is there a school nurse at my school? One thing I just want to mention is that about 25% of schools do not have a school nurse, even with all this COVID pandemic madness going on. And they are a health advocate for you in your school system. So ask that question, does my school have a bachelor's prepared school nurse that can support my child who has a chronic health condition that really needs someone to challenge and support them in the school setting? So my bottom line is get involved, find out what's going on, ask those questions to your school administrators or teacher about the health of your child's school, and also mental health supports. Is there a school counselor, school psychologist? Some schools even have outside community agencies participating in the school setting, providing mental health services for students that need them. So, that would be my recommendation, is to really ask those questions and advocate for your child and the needs that they have in the school.
Thank you. Thank you, Liz. So Paul, last question for you before we get to some questions from the audience. And so if you have a question, make sure to put it in the chat. But Paul, for you, given your experience, obviously in behavioral services and sciences, as well as a parent of a child with obesity, what should be top of mind to help us make progress in closing the health gap that everyone, we've discussed throughout our session today? How can we best partner with families to improve the health of our children?
A great question. It's a huge question. I wish I had an hour. I think the first thing I want to get to is something you've heard the term come up multiple times today from both Liz and Susan. The importance of addressing weight bias. This is within the family, but there's also among healthcare providers. And I got to tell you, I was asked to write an article about this for something called the Bariatric Times, which is a journal dedicated to dealing with weight issues and bariatric surgery and so on. I called it Weight Bias Among Healthcare Providers. We have met the enemy, and it is us. We in the healthcare field are notorious for adding to this. In order to close the healthcare gap, it's crucial that providers start to address this. And I got to tell you, when I wrote the article, I encouraged everybody to assess their biases. If you go online to Harvard University, they have many tests of implicit bias. And you can look at sexual bias and racial bias and ethnic bias and other biases. You can also check weight bias. And anybody who's out there, I'd encourage you to do so. So I looked at it and I took the test myself. And even I had bias. The difference with me, though, my bias was positive. I feel more warmly better about individuals with weight because in general, I find them to be wonderful people, great people, not out to hurt anybody. It's great. And once we can start to break down some of the bias, just as we deal with economic and racial biases and stuff like that, so too when it comes to weight, this is going to be a huge issue in helping kids thrive. I also am a big believer in trying to engage people in leveling the playing field for both healthcare providers and other individuals by using what we call person-first language, where we don't identify kids or adults by the disease state. So I would never talk about an obese child, because this subsumes their identities based on a disease. Instead, I think it's really valuable to start thinking about a child with obesity, adult with diabetes and things like that. So we see people as people rather than objectifying them. Healthcare providers need to acknowledge there has been a dramatic increase in weight with kids. And you've heard a few things that I think Heather, you mentioned, and Susan mentioned too. I was in the airport going to a conference this weekend, and I read an article from Morbidity and Mortality Weekly Report. Took a look at childhood obesity over 1 year. In August 2019, the rate, and the rates are going to vary, but the theme stays the same. Rate was 19.3% of kids. By August 2020, it was 22.4%, a 16% increase in 1 year. So pediatricians and other healthcare providers need to wrap their head around the fact that this thing is spiraling out of control. And as was said before, we need to put more resources into treatment. And as I think Susan eloquently said before, this is a problem that's worse in urban areas with minority populations, where we have food deserts, unsafe areas to walk and play. And if we're ever going to level the playing field, we've got to dedicate more resources to improving these neighborhoods and offering more resources to these families. I think in school, as Liz had started, to speak about, we really should be very much behind healthy school lunch programs and, in some cases, healthy school breakfast programs as the kids are coming back. And I must say, New York State has done a wonderful job of trying to put effort into this and starting to get rid of sugar sweetened beverages, in the schools. So that's not a choice. I would encourage providers to learn from the 5 A's program that was touted by Obesity Canada to engage in meaningful empathic care for treating kids with excess weight. And the message, just eat less and move more, is just plain wrong. It is data that goes back 50 years. It has been outmoded. We should get rid of it as quickly as possible, but that is the go-to message kids and adults get. I think it's also important to help parents and families to appreciate the fact that the largest contribution to excess weight is genetic. It's not human failing. It's not a sign of personal weakness. And then if we can stop blaming kids and stop blaming teens and stop blaming adults, we have a better chance of getting through them and helping to motivate them for subtle shifts. I think we can also take a look at trying to provide more education about how to access healthy foods, cooking classes for families, especially individuals who have kids who are very picky. I will tell you one of my absolute favorite websites, The World According to Eggface. So this is a woman, Shelley Vicari, who had gastric bypass in 2006, and she has a blog which is dedicated to healthy foods, healthy cooking, and a lot of it's really easy. I think we need to, and Liz was just mentioning this too, we need to look at sports opportunities for kids of all sizes, making movement fun. And I will tell you, I think one of the things that helps parents dealing with the kids is get rid of the word exercise. I find it serves no purpose. It's like a 4-letter word to a lot of people. If we can instead talk about movement or physical activity, it doesn't have such a negative valence to it. And, things like dance and yoga and swimming. And for this, Heather, I'm going to go to you because the YMCA is a fantastic. Now, Liz mentioned Boys and Girls Clubs, which are great, but the YMCA is fantastic in terms of providing child, education and teams, and they have the pools. And when you're carrying excess weight, it's much easier to move when you are in water. I also encourage, and our family too, we try to encourage creating a new identity, which is based on physical activity. So we're a family who gardens together, or we go hiking together, activities that anybody of any size can participate in. I think we need to help parents learn that they need to advocate for the kids. They need to build a team of professionals around them, whether it's pediatricians, dietitians, exercise physiologists, whatever it might be, who the child likes. You're never going to get anywhere unless your kid likes. And we went through, about 4 dietitians before we could find one my daughter liked. We found one she loved, and then she moved to Colorado. And that was before Zoom. So we lost her. It took us 5 years to find another really good one. As a psychologist, I also encourage families starting to learn mindfulness skills and coping strategies as alternatives to eating feelings. And this can be as simple as learning diaphragmatic breathing. You can find all these things on YouTube or visual imagery. Last piece I want to mention, this has been alluded to, but politically, in order to kind of close the gap, I would encourage all of you to encourage Congress to pass the Treat and Reduce Obesity Act to help increase counseling resources and medical treatments for obesity for both kids and adults. It is woefully inadequate, and this is one bill which might help to shift that.
Thank you. Thank you, Paul, for mentioning TROA and for sharing some of your thoughts on how we might help close the gap, and for the shout out to the Y. Yes, so there are a lot of youth serving organizations out there who want to partner alongside the school environment and families and clinical partners in helping address childhood obesity. Thank you to my panelists for your amazing insights. And our audience has probably patiently been waiting to ask some of their questions. So again, if you have a question for any of our panelists, please open the chat box and send us your question along with your name and affiliation. And as our audience readies themselves with their questions, I have one for you, Susan. I'm going to direct it to you first. Would you mind sharing a little bit and explaining what a continuum of care approach for childhood obesity would look like in practice, and what do you see as the role of the insurer and the health systems in adopting this approach?
So this is a wonderful point. I'm so glad that you raised it, Heather, this issue of a continuum of care, because I think that this approach is a key way to ensure that children get the most appropriate care at the time that they need it. And so it requires effective communication and connections between the clinic settings, comprehensive multidisciplinary programs, and community institutions. So by employing the electronic medical health record to identify those children who are crossing major percentiles or who are above the 85th or 95th percentile, and to provide decision support tools for prevention and treatment and timely referrals to the next stage of care, these types of approaches as part of this continuum of care is what I think makes a difference. So it takes resources to get this done. And so health systems can help by investing in the resources needed to establish and maintain this type of care, and to foster coordinated the surveillance, not just of weight and BMI, but also of the processes of care. And in addition, health systems and insurers can provide incentives to support this approach and to facilitate provider education and implementation of the evidence-based approaches that we know make a difference in obesity care. And so in this way, a continuum of care approach can also be one of the ways that we aim to eliminate disparities seen in obesity. So we're less likely to sort of not offer something to somebody because we think, well, maybe that won't help them, or maybe they won't use it, or maybe whatever our biases might be. We're being prompted by these systems to actually offer the care that is most likely to help. And so I think in that way, it can also help with disparities, which makes it so important. And again, I'd like to mention that as part of that continuum, the community needs to be part of it. They need to, because community resources are needed to really help children in the places where they live, learn, and play so that they can be in a supportive environment. Dr. Dietz often used to say that we should make the healthiest thing to do the easiest thing to do. And we often think about that in our environments, so what we bring into our home or how we set it up so that we can be more likely to engage in physical activity or other things. But I think we can also take that idea and implement that in the clinical setting so that we make the easiest thing to do, the right thing to do for that child and their weight. And the continuum of care approach can help us do that.
Thank you, Susan. I appreciate that that response. And we have a couple of questions that have come in. So I know we have a couple minutes left. So Liz, I'm going to direct this question to you. And Paul, I have one on deck for you. But Liz, how can children with obesity in difficult home situations, might be financial, emotional, et cetera, be supported both inside and outside of the school setting?
Well, I think it's important to know that there are a lot of supports there for students that schools can provide. I talked a little bit earlier about, connecting them to mental health support within the school, whether that's, the school nurse, school counselor, school psychologist, or even, someone outside of the school. There's also care management or case coordination that goes on for students. And so providing them with the resources that they need, connecting them to healthcare providers, to services, to basic things, food, clothing, internet, whatever is needed in a difficult family situation. Schools really do work to connect those families to the things that they need to support them so they can be successful. So there's, depending on what the needs are, there's lots of opportunity to support them, and just finding out what those are. And also, many schools work with community agencies that also can provide supports for those students that are lacking or have challenges at home. And so, just making those connections and getting them supports that they need through a multidisciplinary team at the school environment is probably the best choice.
Thank you, Liz. An opportunity for all of us to do a little research on the resources available through our schools. Paul, for you, we have a question that's come in from a dietitian who works both in eating disorders and obesity management with children and teens. How do we as healthcare workers create a consistent message for health at every size?
Challenging question. And this walks a
4 minutes.
Yeah. You just give me the softballs, don't you, Heather? I was like, oh, Lord. All right, Paul, how do we solve the world peace question here? You got 2 minutes. Go. So health at every size, in my mind, is very different from people who say that all sizes are healthy necessarily. We need to recognize that there are individuals I see who, and if any of you watched the Summer Olympics, you saw some members of our track and field team who were large women, all right? But they were strong and they were fast and they were medal winners, So being big doesn't necessarily mean you have to be unhealthy. And I also see people who are very thin. And I used to do work in eating disorders and saw, young women with anorexia and bulimia. Being thin does not necessarily mean you're healthy either. What we need to take a look at is the whole person and to recognize health comes in a lot of different shades, so we can talk about physical health, we can talk about mental health, we can talk about good vision, we can talk about good reaction time. Everybody has something that they're good at. And I think by emphasizing an individual's strengths, it makes it much easier for us to then try to address some of the weaknesses. And for somebody to feel like they don't need to get down to some ideal body weight number to be healthier. For most people, most physicians who are trying to help individuals with weight loss, it's 5% of body weight that they're looking at, because at that point, you start to see physiological change in the body. Such that blood sugars start to improve. We see, heart rates tend to improve. And, it's interesting. People get lost in the body mass index. I think it's a terrible number. It's an outmoded thing from the 1950s. It doesn't work. And people, lock onto that. Well, I locked onto it too. I was like, what's going on with this? So I looked up Arnold Schwarzenegger to see what his BMI was when he was Mr. Universe. Turned out he was between a 31 and 32. So he would have been claimed to have obesity as well. We need to teach people that really what we want to focus on is the ability to engage in activity. That's what you want to focus on. And if somebody's struggling in one area, focus on that rather than the weight, because if we can help them to make healthier choices and to realize that, it only takes small steps to eventually reach great gains, they're much more likely to stick with something. If we make them feel like they are a failure because they are of a large size, you are going to see the exact opposite. When we, do things that are shaming for people because science say they got to be a lot smaller, they tend to put more weight on, unfortunately.
Paul, thank you for closing us out today. Thank you to our entire panel.
But wait, I didn't get the world peace.
It's a privilege to learn alongside all of you. Thank you for your time and insights. Obviously, thank you so much to our audience for joining us this afternoon. Don't let the conversation stop here. Continue the conversation by following OCAN on Twitter at Obesity Advocacy and by searching for the OCAN or Obesity Care Advocacy Network on LinkedIn. Thank you so much.